Good afternoon, our dear students, and we are finishing our gastroenterology course and the lectures of internal medicine, and the last topic has the name cirrhosis of the liver. So let's start. I will remind you some anatomy of the liver before we will start our cirrhosis of the liver conversation. The liver is the largest organ of the body, normally weighing about 1.5 kilos, but this can increase to over 10 kilos in case of the chronic cirrhosis. The liver is functionally divided into two lobes, right and left. The external division is marked on the front of the liver by the falciform ligament, which joins the coronary ligament at the superior margin of the liver. The right lobe is separated from the other lobes by the gallbladder fossa and the fossa for the inferior vena cava on the visceral surface of the liver. The left lobe includes the caudate and quadrate lobes and separated from these two lobes by the attachment of the ligament teres and the fissures for the ligamentum teres and the ligamentum venosum. The caudate lobe, the smallest one, lies between the fissure of the fossa ligament venosum and the fossa for the inferior vena cava. The quadrate lobe looks like a quadrate, is partly covered by the gallbladder and the normal patients. Anatomically, it lies between the fissure for the ligament teres and the gallbladder fossa. Each lobe has its own arterial and venous supply and its own biliary drainage. All the lobes perform the same function. There are no areas of specialization. The liver is unusual in that it has a double blood supply. The right and left hepatic arteries carry oxygenated blood for the liver, and the portal vein carries venous blood from the GI tract to the liver. The venous blood from the GI tract drains into the superior and inferior mesenteric veins. These two vessels are then joined by the splenic vein, with posterior to the neck of the pancreas to form the portal vein. This then splits to form the right and the left branches, each supplying about half of the liver. On entering the liver, the blood drains into the hepatic sinusoids, where it's screened by specialized macrophages, Kupffer cells, to remove any pathogens that manage to get past the GI defenses. The plasma is filtered through in the teleal lining of the sinusoids and bathes the hepatocytes. These cells contain vast numbers of enzymes capable of breaking down and metabolizing most of what has been absorbed. The portal venous blood contains all of the products of digestion absorbed from the GI tract. So all useful and unuseful products are processed in the liver before being either released back into the hepatic veins, which join the inferior vena cava just inferior to the diaphragm, or stored in the liver for later use. The morphological and the functional units of the liver are lobules and acini. There are three ways to describe the structure of the liver in terms of these units. There are classical hepatic lobule, portal lobule, and liver acinus. The classical liver lobule, hexagonal in shape, consists of anastomosing plates of hepatocytes separated by the sinusoid capillaries that contain both venous and arterial blood derived from the portal vein and hepatic artery, respectively. At the center of the lobule is a large venule, the terminal hepatic venule, or central vein into which sinusoid capillaries drain. At the angles of the hexagon and are the portal areas in which loose connective tissue ultimately continues with the capsule of the liver, characterized by the presence of portal triads, including branches of the hepatic artery, portal vein, and the bile duct. The portal lobule, triangular in shape, emphasizes the exocrine function of the liver, namely bile secretion. At the center of the portal lobule, a portal space containing portal triad is located. At each age, one central vein is individually placed. So here it is, classical liver lobule, and if we do like this, it will be classical portal lobe. The liver acinus, elliptic in shape, is in the area of which long axis extends from one central vein to the next one, and the short axis extends from one portal space to the next one. The liver acinus is the best to describe the differences in terms of blood perfusion, metabolic activity, and liver pathology among the hepatocytes localized in different zones. Liver is a metabolically complex organ. Hepatocytes perform the liver's metabolic function as formation and excretion of the bile, regulation of carbohydrate hemostasis, lipid synthesis, excretion of plasma oligoproteins, control of cholesterol mechanism, formation of urea, and different type of proteins from clotting factors to enzymes, serum albumin, globulins, etc. Metabolism or toxification of drugs or other toxic foreign substances, storage of different vitamins, glucose, and macroelements, the place of degradation from ammonia drugs to insulin and bilirubin, place of metabolism of carbohydrate and the lipids, and the main one we already named is the synthesis. When examining of the patient, it's important to recognize where the internal organ lie relatively to the surface anatomy you can see. The liver can essentially be visualized as a triangle with its upper margin below the nipples on either side of the chest, and the lower margin making a line from just above the tenth rib of the right side to below the nipple on the left side. The superior surface of the liver lies just below the diaphragm. This means that the lower margin of the liver will move towards on inspiration, and this can be palpated. As the liver is also a very dense organ, it's very dull to percussion, and you can easily percuss out the borders of the liver if palpation is unsuccessful. The gallbladder area can be palpated around the tip of the right ninth rib. The normal gallbladder is unpalpable, but only becomes palpable when distented with stones or bile, or due to hyperfunction or changes in the shape that lead to bile congestion. And the area will become very tender if there is inflammation present. Cirrhosis is defined histologically as a diffuse hepatic process characterized by fibrosis and conversion of the normal liver architecture in structurally abnormal nodules. The progression of liver injury to cirrhosis may occur over several weeks to years. The term cirrhosis was first introduced by Olena in 1826. It's derived from the Greek term cirrus and refers to the orange-brown or tawny surface of the liver seen at autopsy. Clinical features of cirrhosis are the result of pathological changes and mirror severity of the liver disease. Most hepatic pathologists provide an assessment of grading and staging when evaluating liver biopsy samples. Alcohol abuse and viral hepatitis are the most common causes of cirrhosis. Also, non-alcoholic fatty liver disease is emerging as an increasingly important cause nowadays. Chronic alcohol use can produce fibrosis in the absence of accompanying inflammation or necrosis. Other causes of post-hepatic cirrhosis include autoimmune hepatitis and cirrhosis due to non-alcoholic steatohepatitis. Many patients with autoimmune hepatitis present with cirrhosis that is already established. The development of hepatic fibrosis reflects an alternation in the normal balance process of extracellular matrix production and degradation. The extracellular matrix, the normal scaffolding for hepatocytes, is composed of collagens, glycoproteins, and proteoglycans. Stellate cells located in the perisinusoidal space are essential for the production of extracellular matrix. Stellate cells, which were once shown to I2 cells, lymphocytes, or perisinusoidal cells, may become activated into collagen-forming cells by a variety of paracrine factors. Increased collagen deposition in the space of the disc, it's a space between hepatocytes and sinusoids, and the diminution of the size of endothelial fenestra leads to the capillarization of sinusoid. Activated stellate cells also have contractile properties. Capillarization and construction of sinusoids by stellate cells contribute to the development of portal hypertension. Ascites, which is an accumulation of excessive fluid within the peritoneal cavity, can be a complication of either hepatic or non-hepatic disease. The formation of ascites in cirrhosis depends on the presence of unfavorable Starling forces within the hepatic sinusoids and on some degrees of the renal dysfunction. Patients with cirrhosis are observed to have increased hepatic lymphatic flow. Fluid and plasma protein diffuse freely across the highly permeable sinusoidal endothelium into the space of the disc. Fluid in the space of the disc in turn enters the lymphatic channels that run within the portal and the central venous areas on the liver. Because the transsinusoidal oncotic gradient is approximately zero, the increased sinusoidal pressure that develops in portal hypertension increases the amount of the fluid entering the space of disc. When the increased hepatic lymph production observed in the portal hypertension exceeds the ability of the cisterna chyli and the thoracic duct to clear the lymph, fluid crosses into the liver interstitium. Fluid may then extravasate across the liver capsule into the peritoneal cavity. Patients with cirrhosis experience sodium retention, impaired free water excretion, and intravascular volume overload. These abnormalities may occur even in the setting of the normal glomerular filtration rate. They are to some extent due to increased levels of renin and aldosterone. The peripheral arterial vasodilation hypothesis states the splenic arterial vasodilation driven by the high nitric oxide levels leads to intravascular underfilling. The causes stimulation of the renin-angiotensin system and the sympathetic nervous system and results in antidiuretic hormone release. These events are followed by an increase in sodium and water retention and in plasma volume, as well as by the overflow of fluid into the peritoneal cavity. The systemic syndrome can be seen in patients with cirrhosis of the liver is present on the slide, and there are four the main ones. The first one is the portal hypertension, in which architectural and functional changes in liver resulting in increased resistance to portal flow, leading to portosystemic collateral splenic vasodilation, expanded plasma volume, and arterial underfilling. In portopulmonary hypertension, vasoactive substance is not filtered by the damaged liver, causing pulmonary artery vasoconstriction as a reflex response, remodeling of vessels, and in situ thrombosis resulting in increase in pulmonary vasculature resistance and ultimately right heart failure. Hepatopulmonary syndrome appears due to intrapulmonary vascular dilation due to nitric oxide or arteriovenous communication, causes ventilation perfusion mismatch, or shunting, which worsens then when upright due to the dependent pooling of blood at bases. Hepatorenal syndrome appears due to renal failure caused by intense vasoconstriction of the renal circulation as a consequence of extreme underfilling of arterial circulation due to splenic vasodilation and dysregulation of vasocoactive systems in the setting of advanced liver disease. Portal hypertension results from a combination of increased portal venous inflow and increases resistance to portal blood flow. Patients with cirrhosis demonstrate increased splenic arterial flow and accordingly increases splenic venous inflow into the liver. Increased phalangic arterial flow is explained partially by decreased peripheral vascular resistance and increased cardiac output in the patient with cirrhosis. Nitric oxide appears to be a major driving force for this phenomenon. Increased resistance across the sinusoidal vascular bed of the liver is caused by the fixed factors and dynamic factors. Two-thirds of the intrahepatic vascular resistance can be explained by fixed changes in the hepatic architecture. Such changes include the formation of regenerating nodules and, after the production of the collagen by activated stellate cells, deposition of the collagen within the space of the distal. Stellate cells serve as contractile cells for adjustment hepatic endothelial cells. The nitric oxide produced by the endothelial cells, in turn, controls the relative degree of vasodilation or vasoconstriction produced by the stellate cells. In cirrhosis, decreased local production of nitric oxide by endothelial cells permits stellate cells contraction, with resulting vasoconstriction of hepatic sinusoids. Increased local levels of vasoconstricting chemicals, such as endothelin, for example, may also contribute to sinusoidal vasoconstriction. The portal hypertension of cirrhosis is caused by disruption of hepatic sinusoids. This syndrome, hepatorenal 1, represents a continuum of renal dysfunction that may be observed in patients with a combination of cirrhosis and ascites. Hepatorenal syndrome is caused by the vasoconstriction of large and small renal arteries and the impaired renal perfusion that results. The syndrome may represent an imbalance between renal vasoconstriction and vasodilation. Plasma levels of a number of vasoconstricting substances, including angiotensin, antidiuretic hormone, and norepinephrine, are elevated in patients with cirrhosis. Renal perfusion appears to be protected by vasodilators, including prostaglandins and atrial natriuretic factor. Most patients with hepatorenal syndrome are noted to have minimal histological changes in the kidneys. Kidney function usually recovers when patients with cirrhosis and hepatorenal syndrome undergo liver transplantation. Hepatorenal syndrome is diagnosed when a creatinine clearance rate of less than 40 milliliters in a minute is present, or when a serum creatinine level of greater than 1.5 milligram by deciliter, a urine volume of less than 500 milliliters a day, and urine sodium level of less than 10 milliequal by liter are present. Urine osmolarity is greater than plasma osmolarity in this case. International Cirrhosis Organization also updated the definition of hepatorenal syndrome type 1, which now has a term hepatorenal syndrome, acute kidney insufficiency. The 2-week interval required for doubling the serum creatinine for the previous definition could lead to a delay on starting treatment for hepatorenal syndrome. Several studies have shown that the higher the creatinine at the start of the treatment, the low probability of reversal of hepatorenal syndrome. Therefore, no minimal creatinine value is needed for diagnosis according to the updated definition. And this syndrome type 1 can be diagnosed even when the serum creatinine is below 2.5 milligram by deciliter. Now you can see that increasing the serum of creatinine more than 0.3 milligram by deciliter for last 48 hours. No response to diuretic withdrawal, cirrhosis with ascites, absence of the shock, no current or recent use of nephrotic drugs, no signs of structural kidney injury can help you to make diagnosis hepatorenal syndrome type 1, or now the correct term hepatorenal syndrome acute kidney injury. Functional kidney injury in patients with cirrhosis that does not meet criteria for the first type of hepatorenal syndrome is termed hepatorenal syndrome, no acute kidney injury, and is defined by estimated glomerular filtration rate rather than the serum creatinine. This type 2 of the syndrome is divided into acute kidney disease if the glomerular filtration rate is less than 60 milliliter by minute by the 1.73 meters quadratic of the surface of the body for less than 3 months, and hepatorenal syndrome chronic kidney disease type 2 if it's less than this for more than 3 months. Hyponatremia, high plasma renin activity and liver size, as well as severity of ascites, are predictors of acute kidney injury, hepatorenal syndrome. Acute hemodynamic changes associated with infection and large volume paracentesis without albumin administration represent the most common precipitants of this disorder, and the prevalence of antiprecipitated acute kidney injury is low. Type 1 syndrome develops, type 2, syndrome develops is in the 30% of patients with spontaneous bacterial peritonitis as well as other infections, and is associated with worse outcome. Hepatic encephalopathy syndrome observed in some patients with cirrhosis is marked by personality changes, intellectual impairment, and depressed level of consciousness. The diversion of portal blood into the systemic circulation appears to be a prerequisite for the syndrome. Indeed, hepatic encephalopathy may develop in patients without cirrhosis who undergo portocaval shunt surgery. There are two major hypotheses for hepatic encephalopathy appearance. First one is ammonia hypothesis, when ammonia is produced by GI tract by the bacterial degradation of amines, amino acids, purines, and the urea. Normally, ammonia is detoxified in the liver by conversion to urea and glutamine. In liver disease or portosystemic shunting, portal blood ammonia is not converted efficiently to urea. Increased levels of ammonia may enter the systemic circulation because of portosystemic shunting. Ammonia has multiple neurotoxic effects, including alteration of the transit of amino acids, water, and electrolytes across the neuronal membrane. Ammonia can also inhibit the generation of excitatory and inhibitory postsynaptic potentials. Therapeutic strategies to reduce serum ammonia levels tend to improve hepatic encephalopathy. There is also gamma aminobutyric acid hypothesis of hepatic encephalopathy, and this gamma aminobutyric acid is a neuroinhibitory substance produced in the GI tract. It was postulated that the substance crosses the extrapermeable blood-brain barriers of the patient with cirrhosis and then interacts with supersensitive postsynaptic GABA receptors. That would lead to generation of inhibitory postsynaptic potentials. Clinically, this interaction was believed to produce the symptom of hepatic encephalopathy. Subsequent work has suggested that brain levels of GABA is not increased in patients with cirrhosis. However, brain levels of neurosteroids are increased in patients with cirrhosis. They are capable of binding to their receptor with a neuronal GABA receptor complex and can increase inhibitory neurotransmission. Clinical features of cirrhosis include jaundice and scleral icterus, which is a yellow discoloration of the skin, cornea, and mucous membranes because of increased serum bilirubin levels due to compromised hepatocyte excretory function. Spider angiomata, it's a central and arteriole with tiny radiating vessels, main and trunk on the face. The dilation of them is or can be explained by raised estradiol levels due to decreased its degradation in the liver. Palmar erythema, it's erythema sparing central portion of the palm with unknown cause of appearance. Gynecomastia and loss of the male hair pattern, which gynecomastia is benign proliferation of glandular male breast tissue. With the loss of the male hair pattern and appearance of decreasing of the sexual function due to elevated estradiol levels, hypogonadism due to alcoholic cirrhosis and hemochromatosis, mostly due to similar raised estradiol levels due to decreased degradation in liver, and direct toxic effect of alcohol or iron. Nodular liver as irregular hard surface on palpation presented due to fibrotic changes with irregular regeneration, or in case of hepatocellular carcinoma, normal cell conversion. Splenomegaly or enlarged spleen due to examination by palpation or ultrasound in patient with portal hypertension or splenic congestion. Caput medusae sorry, here you can see it clearly. It's a prominent vein radiating from umbilicus in patient with portal hypertension due to opening of umbilical vein that shunts blood from the portal vein under the pressure. Ascites is the presence of proteinaceous fluid in the abdominal cavity, clearly seen by ultrasound in the small quantities, but clinically detected if more than 1.5 liters present in patient of cirrhosis. Explained can be by portal hypertension, hypoalbuminemia leads or hypoalbuminemia, which leads to loss of oncotic pressure, so can be present in patient with hepatocellular carcinoma as a sign of carcinoid syndrome. Petechiae, purpura, and bleeding appears in patient with cirrhosis due to thrombocytopenia, gastric varices, or hemorrhoids. Due to sequestration of the spleen, low thrombopoietin production, in case of thrombocytopenia, presence of portal hypertension or decreased clotting factor, as synthetic function of the liver is inadequate in the patient with cirrhosis. Leukocyte nails presented on the picture from the right side. It's a horizontal white band, so proximal white nail plate, due to hypoalbuminemia and decrease in vascularity and increase in connective tissue production in the nail bed. Finger clubbing appears due to hypoxia associated with Hepatopulmonary Syndrome or Pulmonary Hypertension. Clear mechanism is unknown, but usually present in patients with long-term chronic hypoxic states. Dyspnea and hypoxia due to in patient with Hepatopulmonary Syndrome due to decrease of oxygenation, anorexia, fatigue, weight loss, muscular wasting due to catabolic metabolism in the increasing levels in the liver, secondary to anorexia in patient with hepatocellular carcinomas and presence of carcinoid syndrome. In case of anemia, patient will have fatigue due to hypoxia. Dupuytren contracture happens if fibrosis and contraction of the pulmonary fascia appears due to enhanced oxidative stress and increased inosine levels, not specific only for cirrhosis, but especially can be present in case of alcoholic exposure or diabetes concomitant in patient with cirrhosis. Asterisk, it's synchronous flapping motion of dorsiflexed hands due to dysregulation of ammonia metabolism and hepatic encephalopathy, which leads to disinhibition of the motor neurons. Confusion and hepatic encephalopathy we already discussed, and fetor hepaticus, it's a sweet pungent smell due to volatile dimethyl feed, especially in portosystemic shunting and liver failure. The symptoms of hepatic encephalopathy may range from mild to severe and may be observed in 70% of patients with cirrhosis, are graded on the following scale from 0 to 4, where the 4 is a coma and 0 is subclinical presentation and minimal changes in the memory, concentration, or intellectual function. Patient with mild to moderate hepatic encephalopathy demonstrate decreased short-term memory and concentration of the mental status tasting. We have specific tests for hepatic encephalopathy when patient need to connect numbers from 1 to 20, and the physician during physical examination after this test will evaluate the level of cognitive function of the patient and the time of this this test will be finished. Also, this patient can have asterisks or fetor hepaticus or fetor hepaticus. An elevated arterial or venous serum ammonia levels, the classic laboratory abnormality reported in the patient with hepatic encephalopathy. Patients with cirrhosis may have impaired pulmonary function, already named, and pleural effusion and diaphragmatic elevation caused by the massive ascites may alter ventilation perfusion relations. Interstitial edema or dilated precapillary pulmonary vessels may reduce pulmonary diffusing capacity. Patients also may have Hepatopulmonary Syndrome. Its condition, pulmonary arteriovenous anastomosis, result in arteriovenous shunting. This syndrome is a potentially progressive and life-threatening complication of cirrhosis. Classic syndrome is sparked by the symptom of platypnea, it's a shortness of the breath relieved when lying down and worsened when sitting or standing, and the finding of orthodeoxia. It's a decrease in the arterial oxygen tension when the patient moves from a supine to an upright position. But the syndrome must be considered in any patient with cirrhosis who has evidence of oxygen desaturation. Hepatopulmonary syndrome is detected mostly readily by the echographic visualization of the late appearing bubbles in the left atrium following the injection of agitated saline. Patient can receive a diagnosis for the syndrome when the partial oxygen pressure is less than 70 millimeters. Some causes may be corrected by liver transplantation, and in fact, the patient course to the liver transplantation may be expedited when his or her partial pressure of oxygen is less than 60 millimeters. Pulmonary hypertension observed up to 6 patients with cirrhosis. Etiology is unknown, and this disorder is defined as the presence of a mean pulmonary artery pressure of greater than 25 millimeters in the setting of normal pulmonary capillary wedge pressure. I should remind that pulmonary hypertension is pulmonary pressure, artery pressure more than 15 millimeters. Laboratory abnormalities can be seen in patients with cirrhosis. Consist of normal or moderately raised levels of AST, ALT. Most severe cirrhosis is less high AST or ALT levels will be, as diffuse cirrhosis results in loss of normal hepatocytes quantity, which an IST and ALT, especially ALT, as we know, it's a marker of the normal liver cells damage. In case if it's alcoholic patient, or in case if it's cholestatic causes of cirrhosis, GGT levels can be elevated. Alkaline phosphatase levels increased by less than 3 folds, or in case of cholestasis as a mechanism of cirrhotic problems, or as concomitant appearance. Anemia, usually microcytic, normal, or macrocytic, depending on the cause. It's hemorrhagic due to bleeding, or it's folate B12 deficient, in this case macrocytic. In case of malnutrition, complication for cirrhosis. Prothrombin time usually decreased in patients in advanced cirrhosis due to abnormal synthetic function on the liver. In this case, the level of hepatic production of the clotting factors is low due to cirrhosis. Thrombocytopenia presence in patients with cirrhosis due to splenomegaly, reduced hepatic production of thrombopoietin, or direct toxic effect of alcohol on the bone marrow. Low level of albumin seen in the serum in patients with advanced cirrhosis due to decreased hepatic production and sequestration into ascites and interstitium, or malnutrition of this patient. Patient with cirrhosis has low levels of albumin, but increased levels of immunoglobulin, especially immunoglobulin G, due to shunting of the portal venous blood carrying antigens to lymph tissues with resultant stimulation of the plasma cells. Hyponatremia explained by sodium and water imbalance, appears due to inability to excrete free water via kidneys due to increased activity of vasopressin, arterial underlying leading to the activation of renin-angiotensin system and water retention, or secondary complications of portal hypertension and splanchnic vasodilation. Splanchnic is internal organs, yeah, vasodilation. Held and Turcotte firstly introduced their scoring system in 1944 for assessment of severity of cirrhosis as a means of predicting the operative mortality associated with the portal-caval shunt surgery. Pew revised system in 1973 substitute albumin for the less specific variable of nutritional status. Subsequent revisions have used the international ratio in addition to prothrombin time, and nowadays the assessment of severity consists of the presence or absence and severity of encephalopathy, ascites, bilirubin levels, bilirubin patients without or with the biliary cirrhosis or cholangitis as a cause of cirrhosis, albumin levels and their loss, and prothrombin time, which is increased with the progression of the disorder. Calculation of these points leads to the classes. So if 5 points, the class A and means mild cirrhosis, where the class C tends to 10 to 15 points is the severe cirrhosis. Ultrasound is a major screening tool for cirrhosis and its complications. It's also useful to aid for biopsy. Appearance includes surface nodularity, overall coarse and heterogeneous echo texture, segmental hyper or hypertrophy, caudate wide means enlargement of the lobes of the liver, reduction of the transverse diameter of the medial segment of the lobe, signs of the portal hypertension. So usual changes in hepatitis, it's increasing of the size of the liver. Usual changes in cirrhosis is decreasing of the sizes of the liver. Doppler flow changes consist of portal venous system, large changes, which large portal vein, slow portal venous flow, reversal or to and from portal venous flow, portal venous thrombosis. This should be measured during the deep inspiration as size can vary, and loss of respiratory variations and splenic in spectrodoppler waveforms. Elastography is a newer technique that explores the fact that the pathological process alters the elastic properties of the involved tissue. This change in elasticity is detected and imaged using elastography. Zone elastography is a term when we can use ultrasound to assess elastography. Also, we can use MRI to assess elastography, depending on the skills of your technician and presence or absence of ultrasound or MRI. The type of the elastography can be actually chosen. MRI elastography has been mostly widely used in case of the liver fibrosis, where the larger lesions can be easily assessed even in the presence of ascites. CT of the liver is unsensitive in early cirrhosis, and more established findings include surface and parenchymal nodularity, regenerative nodules, sclerotic or siderotic nodules, fatty change, parenchymal heterogeneity, predominantly portal vein supply to dysplastic nodules in advanced cirrhosis, signs of portal hypertension, portal vein enlargement, thrombosis, portal vein thrombosis or cavernous transformation, splenomegaly, or portosystemic collaterals. Biopsy is considered the gold standard for diagnosis of cirrhosis, and sequential histological gradient of inflammation and staging of fibrosis can assess risk of progression. A liver biopsy is obtained by either radiologically guided percutaneous or radiologically guided, usually it's ultrasound guided, percutaneous, transjugular, or laparoscopic route. A greater risk of bleeding following a biopsy has been observed with larger diameter needles. In suspected cirrhosis, a cutting is preferred over the section needle in order to prevent tissue fragmentation. Histologically, cirrhosis is characterized by a vascularized fibrotic septa that link portal tracts with each other and with central veins leading to hepatocyte islands that are surrounded by fibrotic septa and which are devoid of the central vein. But you should remember, despite the pathological changes, the liver is highly vascularized organ, and an appropriate technique of liver biopsy or an appropriate education, level of specialist can lead to complication, which is peritonitis and of course bleeding. So elastography and ultrasound in this case, in some cases, is more reliable despite biopsy is a gold standard. Only the biopsy can give the best answer on what happens and what kind of structural changes happens, and is it liver cirrhosis or maybe carcinoma. In 2020 or 2010, I'm sorry, practice guidelines for liver diseases of American College of Gastroenterology recommend aggressive treatment of protein-calorie malnutrition in patients with alcoholic cirrhosis. Multiple feedings per day, including breakfast and a snack at night, are specified. Regular exercise, including walking and even swimming, should be encouraged in patients with cirrhosis to prevent these patients from slipping into the vicious cycle of inactivity and muscular wasting. Debilitated patients frequently benefit from a formal exercise program supervised by a physical therapist. Specific medical therapies may be applied to many liver diseases in an effort to diminish symptoms and to prevent or forestall the development of cirrhosis. Examples include prednisone and azathioprine for autoimmune hepatitis, interferon and other antiviral agents for hepatitis B and C, phlebotomy for hemochromatosis, ursodeoxycholic cholic acid for primary biliary cholangitis, and trientine and zinc for Wilson disease. Zinc deficiency commonly is observed in patients with cirrhosis. Treatment with zinc sulfate and 2020 milligrams orally twice daily may improve dysgeusia and can stimulate appetite. Furthermore, zinc is effective in the treatment of muscular cramps and is adjunctive therapy for hepatic encephalopathy. Pruritus is the most common complaint in cholestatic liver disease and is non-cholestatic chronic liver disease. Also, increased serum bile level acid levels on ones were thought to be a cause of pruritus. Endogenous opioids are most likely to be the culprit pruritogen. Also, mild itching complaints may respond to treatment with antihistamines and topical ammonium lactate. Cholestyramine is the mainstay of therapy for the pruritus of liver disease. Some patients suffer from hypogonadism, and these patients with severe symptoms may undergo therapy for topical testosterone preparation. Patients with cirrhosis may develop osteoporosis. Supplementation with the calcium and vitamin D is important to the patient at higher risk of osteoporosis, especially patients with chronic cholestasis or primary biliary cholangitis, and patients receiving corticosteroids for autoimmune hepatitis. The finding on bone densitometry studies or decreased bone mineralization may prompt the institution of therapy with an aminobutyric. Patients with chronic liver disease should receive vaccination to protect them against hepatitis A. Other protective measures include vaccination against influenza and pneumococci. The updated diagnostic criteria with removal of minimum serum creatinine concentration allow early diagnostic treatment of hepatorenal syndrome type 1 rather than waiting for a doubling of creatinine. Drug treatment may be started immediately after an unsuccessful fluid challenge. Stage 1A is the most often secondary to hypovolemia and is expected to resolve in more than 90% of patients. at this stage, compared with half of the patient with the stage 1B with high levels of creatinine. Therefore, European Association of the Study of the Liver recommend resorting to use of vasoconstrictors for patients with stage 1B and greater. Planned vasoconstriction in patients with cirrhosis result in reduction of portal pressure and increasing of renal blood flow, especially when combined with intravenous administration of albumin. Renal perfusion directly correlates with the changes and negatively affected by intra-abdominal pressure driven by ascites. Norepinephrine intravenously and midodrine orally asymptomatic vasoconstrictors sought activation through the activation of alpha-1 adrenergic receptors of vascular smooth muscular cells. Osteotide is a somatostatin analog, acts by inhibiting secretion of glucagon and Planck vasodilator and is a direct mesenteric vasoconstrictor. Once diagnosis of type 1 of hepatorenal syndrome established, management of hepatorenal syndrome starts with the fluid challenge of up to 25 intravenous albumin at 1 gram by kilogram a day for 2 days and withdrawal of diuretics. This initial phase also includes temporal discontinuation of non-selective beta blockers given their negative inotropic effect, which reduces cardiac output. The creation of an intrahepatic shunt aimed to reduce portal pressure has shown significant benefit in patients with cirrhosis who cannot tolerate diuretics or have refractory ascites and who have uncontrolled variceal bleeding. The functional nature of hepatorenal syndrome means the improvement in renal function is expected with liver transplantation, which remains the optimal treatment whenever is feasible. Non-hepatic causes of altered mental function must be excluded in patients with cirrhosis who have worsened mental function. Medications that depress central nervous system function, especially benzodiazepines, should be avoided. Precipitants of hepatic encephalopathy should be corrected. Lactulose is helpful in patients with an acute onset of severe encephalopathy symptom and is patient with a milder chronic symptoms. This non-absorbable disaccharides stimulate the passage of ammonia from tissues into the gut lumen and inhibits intestinal ammonia production. Initial lactulose dosing in 30 milliliter orally once and twice daily. Dosing increased until the patient has from 2 to 4 stools per day. Dosing should be reduced if the patient complains of diarrhea, abdominal cramping, or bloating. Neomycin and other antibiotics serve as second-line agents. They work by decreasing of colonic concentration of aminogenic bacteria and can prevent complications as bacterial peritonitis. Treatment with neomycin may be complicated by toxicity and nephrotoxicity, and we should remember about it. Other chemicals capable of decreasing blood ammonia levels are L-ornithine, L-aspartate, which are available in Europe, and sodium benzoate, which is more widely available. Low-protein diet were recommended routinely in the past for patients with cirrhosis, and high level of aromatic amino acids contained in animal proteins were believed to lead to increased blood vessels of the false neurotransmitters tyramine and octapamine, with resultant worsening of encephalopathic symptoms. In this adverse experience, the vast majority of patients can tolerate the protein-rich diet that includes well-cooked chicken, fish, vegetable protein, and, if needed, protein supplements. I should remind you that patient with severe ascites, for patients with severe ascites, can be referred to surgery for paracentesis to actually eliminate additional fluid from the abdominal cavity, and in this case all fluid should not be removed from the abdominal cavity of the patient with cirrhosis or severe hepatitis, as this abdominal fluid contain a lot of proteins, and elimination of these proteins from the patient body and this fluid from the patient body leads to loss of the pressure, oncotic pressure, and sometimes even death of the patient. Liver transplantation has emerged as an important strategy in the management of the patient with decompensated cirrhosis. Patients should be referred for consideration of liver transplantation after the first sign of hepatic decompensation. Contraindication for liver transplantation include several cardiovascular or pulmonary disease, active drug or alcohol abuse, malignancy outside of the liver, sepsis, and psychosocial problems that might jeopardize patient abilities to follow their medical regimen after transplant. According to the 2010 guidelines, a patient whose end-stage liver disease is alcohol-related should be considered as candidates for transplantation after medical and psychosocial evaluation that includes formal assessment of the probability of long-term abstinence. The clinical course of the patient with advanced cirrhosis is often complicated by a number of important sequelae that can occur regardless of the underlying cause of the liver disease. These include already named portal hypertension, gastroesophageal variceal hemorrhage, splenomegaly, ascites, hepatic encephalopathy, more severe and life-threatening spontaneous bacterial peritonitis, hepatorenal syndrome, and hepatocellular carcinoma, and also hepatopulmonary syndrome we discussed in this lecture. Pulmonary complication in the form of the hepatopulmonary syndrome, portopulmonary hypertension, and hepatic hydrotorx are rare occurrence in the patient with portal hypertension and liver cirrhosis. They are associated with the high morbidity and mortality, and the only effective therapy is the liver transplantation in the patient who are suitable. Thank you for your attention during this gastroenterology course, and we have two left. It's hematology and pulmonology, so see you then. And as usual, if you do have any question, please put them under this lecture on our Facebook page or send me it via my email that you can find actually in our web page. Thank you and goodbye.